Let's begin. So I have nothing to disclose. As we are all familiar with, endometriosis is a chronic estrogen-dependent disease, and the incidence runs around 10% of women at reproductive age. The most common symptoms are dysmenorrhea, dyspareunia, and infertility. Now, the morphological presentation of endometriosis is diverse. When it comes to pelvic endometriosis, three main entities coexist: peritoneal, ovarian, which means endometrioma, and deep infiltrating endometriosis. Presented in this slide counterclockwise, the clinical presentation of peritoneal endometriosis, and down below a deep infiltrating lesion nodule, which is demonstrated as well in MRI imaging, and on the right side, ovarian cyst of endometriosis, which is clearly evident in the ultrasound. Nowadays, there is a common understanding that diagnostic laparoscopy is not mandatory in order to initiate treatment in patients presenting with symptoms suggestive of endometriosis. Now, the combination of patients' medical history and physical exam itself has a sensitivity of 70%. In recent years, time and effort have been invested to identify genetic, immune, or inflammatory markers of endometriosis in blood. And the goal is to find a marker with at least a 90% of positive and negative predictive value. However, so far, no biomarkers have been validated for a non-invasive diagnostic test for endometriosis. So how can imaging modalities assist us to improve diagnosis? Specifically, no imaging technique can detect peritoneal endometriosis. In the case of endometriotic cyst, however, pelvic ultrasound is a valuable diagnostic tool. When it comes to deep infiltrative endometriosis, the accuracy rate is variable depending on nodal location, as shown in this slide. When we are assisted by transvaginal sonography, study shows that independently of deep endometriosis location, sensitivity reaches almost 80% and specificity 94%. And in case of rectosigmoid endometriosis, the accuracy rate is better. If we look at the MRI, again, independently of DIA location, the sensitivity is 94% and specificity 77%. Also in this case, when it comes to rectosigmoid nodule, both sensitivity and specificity are high. So if we compare it to laparoscopy, it is quite, we can quite confident say that both transvaginal sonography and MRI, they reach at least a value of triage test for deep endometriosis, meaning we can rule out endometriosis based on these modalities. And specifically, if we have suspected rectosigmoid endometriosis, we can clearly identify the disease based on these modalities. Some advocate for a sequential use of both modalities in order to improve accuracy. So, given that most women with endometriosis, they present with pain, infertility, or both, the goals of treatment are to reduce pain, preserve or improve fertility, and improve quality of life. Understanding that endometriosis is a chronic disease, a long-term medical treatment, or more specifically hormonal treatment, should be implemented. This treatment will be stopped when pregnancy is desired and is to be resumed following delivery. Surgical treatment will be presented in the case of failure to conceive spontaneously or for other specific indications. Alternatively, ART therapy may be chosen first. This table shows a few studies or few analyses made by the Cochrane database. And the bottom line is that there is no consensus regarding what is the best therapy, hormone therapy, in case of endometriosis. As in other chronic diseases, one should consider the cost effectiveness of the drug, how well it will be or is tolerated by the patient. It should be low risk since the drug will be taken for a long term. So the first line treatment is pain medication, mainly NSAIDs, combined oral contraceptive hormones, or derivatives of progestins such as pills, injection, Depo-Provera, or IUD containing progesterone. And the second line mainly are GnRH agonist or GnRH receptor antagonist. Now, up to 30% of patients either don't respond to first-line treatment, they have intolerance or have contraindications. Medical therapy have shown benefit in preventing recurrence of symptoms compared with surgery alone. So here, this slide also simplifies the algorithm, how should we treat or relate to patients with endometriosis-associated pain. The first line treatment will be either combined oral contraceptive pills, continuously or cyclic, although the continuous mode is better, approach is better, or the use of progestin. But in the absence of improvement, pending or understanding that we need at least a 3 months period in order to reach such conclusion, then we have two options, either to perform laparoscopy for diagnosis and treatment, or to escalate the treatment to GnRH agonist or antagonist. Now this slide is very important. It presents the estrogen threshold hypothesis. This is the basis for GnRH agonist treatment with EDVAC. So our goal is to reduce or bring down the level of estrogen concentration in order to cause amenorrhea and as a byproduct halt or minimize the growth of endometriosis with limited side effects. However, if we'll bring the estrogen concentration to a lower level, too low, then the patients will suffer from the hypoestrogenic state and undesirable side effects of estrogen depletion, such as vasomotor symptoms and bone loss. On the other hand, if the estrogen level is not decreased enough, we will not achieve our goals, and the end result will be disease progression. Now, this slide presented on the last slide, starting on the left side, are the physiological effect of pulsatile GnRH release on estrogen level. Now, when we administer a GnRH agonist, the first response will be a flare effect, high estrogen levels, followed by a substantial inhibition or desensitization of the hypothalamic pituitary axis. This results in a hypoestrogenic state. The administration of a GnRH antagonist, however, results in a lower estrogen level while avoiding both extremes of the flare effect and hypoestrogenic state. In 2017, a novel drug called Elagolix was presented to the market. It's an oral non-peptide GnRH antagonist having short life of 4 to 6 hours, no flare effect. It's rapid, reversible, and dose-dependent suppression of the axis, and it enables maximum flexibility to physicians. two regimens were presented: partial suppression at 100 milligram once daily, or the highest dose of 200 milligram twice daily, causing nearly full suppression, as you can see by the diagrams. Now, in 2017, March 2017, the first RCT trial of elagolix was published in the New England Journal of Medicine. The EM1 and EM2, which signifies for the study presented or conducted in North America, EM2 was the same study conducted globally. Essentially was the first three studies evaluating the effect of two doses of elagolix versus placebo in women with moderate to severe endometriosis associated pain. It should be mentioned that this patient had a surgical proven endometriosis in the period time of 10 years prior to the initiation of the study. What were the conclusion criteria? Premenopausal woman between 18 and 49 years old with a surgical diagnosis of endometriosis, as I said, and moderate to severe disease. A patient with a z-score, BMD z-score less than 1, minus 1.5 were excluded from the surgery. Approximately 75 to 80% of elagolix women that completed the first phase, the EM1, EM2 double-blind study for a half year, they enrolled in the extension studies aiming to evaluate the impact of an extended time period of treatment for these patients in two regimens. So this slide focuses on the effect of elagolix on dysmenorrhea in non-menstrual pelvic pain. And as we can see, there were significant differences in when it comes to pain relief in case of dysmenorrhea in non-menstrual pelvic pain. And these significant improvements, they were seen with each dose at elagolix, of elagolix at 3 months and 6 month period. Now, this slide shows the effects on dyspareunia. And compared to the placebo, the responder rate for dyspareunia was significantly higher with elagolix 200 milligrams twice daily at 3 and 6 months. But it was not significant versus the placebo with 150 milligrams. Improvement in this pareunia seen with 200 milligrams twice daily were sustained through 12 months treatment, the elagolix 3 and 4, okay? This table summarizes the side effects or adverse events of the drug, mainly vasomotor symptoms, more specifically hot flashes or night sweats and headaches. However, when we compare it to what we know in the literature following the treatment of GnRH agonist, these side effects were less common, significantly less common. Discontinuation were most commonly due to, again, hot flashes or night sweats, around 1% with 100 milligrams once daily and 2.5% with 200 milligrams twice daily, and nausea as well. Amenorrhea was achieved in up to 27% of patients being assigned to the lower dose and 60% at the higher dose. This slide focuses on the impact of elagolix on the bone mineral density. And again, there are significant changes, reduction of bone mineral density, but still no case reached osteoporosis, and no one had a z-score below 2 even following a 1 year period of treatment. So to summarize, elagolix is an oral GnRH antagonist shown to have rapid and reversible hormone suppression with dose-dependent estradiol suppression. Adverse events associated with reduced estradiol level were seen with elagolix, including hot flashes and decrease in BMD and increases in serum lipid levels. Now, this continuation due to adverse events range between 4 to 10% in elagolix-treated women up to 1 year. And both doses of elagolix achieved a significant improvement in dysmenorrhea and non-menstrual pelvic pain at 3 and 6 months. When it comes to a longer period of time, elagolix 200 milligram achieved a significant improvement in dyspareunia and reduction in use of rescue and analgesic at 3 to 6 months. And as demonstrated in the extension studies, efficacy of elagolix was maintained after 12 months of continuous treatment, but mainly the high dose. Thank you so much.